This conference will now be recorded.
So, I am Dr. VijayShankar, Department of Assistant Professor, Department of Orthopaedics. Today, the topic for discussion is thoracic outlet syndrome. So, the term thoracic outlet syndrome was originally coined by RMPT in 1956. Coming to definition, it is a thoracic outlet syndrome is a neurovascular symptom in the upper extremities due to pressure on the nerves and vessels in the thoracic outlet area. The specific structures compressed are usually the nerves of brachial plexus and occasionally subclavian artery and vein. So coming to pathogenesis, depending on the exact site of injury and the injury component of neurovascular bundle, three distinct syndromes are a combination of this may be encountered. Usually they may be neurological syndrome, venous syndrome or arterial syndrome. Most of the times it is a neurological system which is involved, and it is involves around 95%. The symptoms and signs are mixed among these three types. They should be called a predominant neuro. If the nervous system is involved, then it is known as predominant neurogenic. If the arterial system is involved, then we can say it is predominant arterial system. Or if the venous system is involved, then we can say it is venous thoracic outlet syndrome. So they are again divided into complicated and uncomplicated. So uncomplicated is the symptoms are usually mild. They are usually misdiagnosed. Their complication is the severe symptom. They may lead to complicated TOS. So this diagnosis may take place from 3 months to 15 years to diagnose this as a thoracic outlet, complicated thoracic outlet syndrome. So coming to classification, we can classify this thoracic outlet syndrome based on symptom into uncomplicated thoracic outlet syndrome and complicated thoracic outlet syndrome. So uncomplicated, again it is again divided into predominant neurogenic, predominant arterial and predominant venous type. So this uncomplicated form is the most common and most undiagnosed or misdiagnosed. The uncomplicated form can present with a mild to severe pain or just mild or severe pain, positional paresthesias, or there will be no atrophy of hand muscles. Okay, there is no motor symptoms or atrophy of just mild symptoms will be there in the case of uncomplicated thoracic outlet syndrome. These are symptoms are usually intermittent or oscillating. So the complicated form is easy to diagnose. So the signs and symptoms of complicated form are slowly progressive unilateral atropic weakness. So there is a weakness of intrinsic hand muscles and sensory abnormality of C8 and T1 distribution in neurogenic type. Okay, and if it arterial system is involved, then we will have a non-positional ischemia of fingers and hands, thrombus and embolism arteries of upper extremities, and subclavian aneurysms and cerebral embolisms. Okay, in venous thrombosis, venous type of thoracic outlet syndrome, we have venous thrombosis of subclavian and axillary veins, and the signs and symptoms of this. So usually you will have a pain and paresthesias of upper extremities in all the three types. So coming to epidemiology, incidence is 1 to 2%. Age is usually 20 to 50 years of age. Sex females are more prone for this. Ratio is 3:1. So mostly neurogenic thoracic outlet syndrome accounts for more than 95% because these are the nerves are the first which respond to this compression at the outlet. Okay, and venous accounts for 4%, arterial accounts for 1%. So what is this thoracic outlet, where it is get compressed? So coming to anatomy, we have three spaces in the thoracic outlet region. We have interscalene triangle. So interscalene triangle is inferiorly it is bounded by first rib, anterior by scalenus anterior and posterior by scalenus medius. So costoclavicular space, it is a space between the rib and clavicle. So anteriorly it is bounded by clavicle and subclavius muscle, and posteromedially by first rib, and posterolaterally by superior border of scapula. And something called as when you get some distally, you will have a pectoralis minor space. It is bounded anterior by pectoralis minor muscle and posterior by chest wall. So this is the diagram showing the outlets. So superiorly you can see the scalenus medius and anterior, and a space between that. We can see the brachial flexus and subclavian artery emerging from the uh, scalenus triangle. Okay, and we can see thoracic outlet, and this is between the space between clavicle and first rib. You can see that clavicle and first rib, and this is the pectoralis minor muscle. Below that pectoralis minor, we will have space. So you can see here it is scalenus triangle. The brachial plexus and subclavian arteries involved. Okay, in the costoclavicular area, we will have it is between the clavicle and the first rib, and medially you can see subclavian vein, and in scalenus triangle you can see that artery and brachial plexus. So pectoral below figure shows the pectoral minor space. This is pectoralis minor muscle, and it originates from the corpora post and inserted on the first 3, 4, and 5 ribs. So below that is the passage of this brachial flexus and subclavian artery and vein. So in scalenus triangle, there we can see the brachial flexus, upper brachial flexus injury or subclavian gland involved, and in pectoral minor, all the three are involved. So these are contents in interscalene triangle. We have brachial flexus and subclavian artery, and in costoclavicular vein is seen in the corpoclavicular space, and all are seen in the case of pectoral minor space. So what is coming to etiology? We have anatomical defects like bony abnormalities. So this thoracic outlet syndrome is seen in the case of cervical rib or a long C7 transverse vertebrae. So abnormal bands and ligaments in the C7, or a fractured clavicular first rib, or exostosis. Coming to muscle anomalies, we have anomalous insertion of scalenus muscles, scalenus muscle hypertrophy, or scalenus minus hypertrophy. So pass the brachial plexus to the substance of anti-scalene muscles. A broad excessive anterior and middle scalene muscle insertion on the first rib. So you may have other etiologies are tumors and trauma, and a poor posture, drooping of shoulder or holding the head in a forward position. So sometimes repeated activity may lead to thoracic outlet syndrome, as seen in the case of typing the computer athletes, swimmers, or baseball pitchers, and we can see in case of obesity and pregnancy also. So coming to cervical rib. So usually cervical vertebrae do not give rise to any ribs. In cervical rib, extra rib is formed, and known as from the 7th cervical vertebra. Sometimes we also call it neck ribs. So congenital abnormality located above the normal first rib. A cervical rib present in less than 1% of the normal population, and have been reported to lead to 5 to 9% of patients with thoracic outlets. So bilateral cervical rib present. Bilateral is in 50% and more common right side. Usually the cervical ribs are asymptomatic. As you see here, you can see the picture of a cervical rib with fibrous band attached to the first rib. So it leads to, in the right side, you can see that it is compressing the right subclavian artery, and we can see the post-stenotic dilatation of the subclavian artery there. So this is X-ray of a cervical spine, AP and lateral, showing the cervical rib arranged from the C7 vertebrae. So coming to clinical features, we have to differentiate the clinical features into broad headings like neurogenic thoracic outlet syndrome, venous and arterial variant. Okay. So usually the clinical features are more of the neurogenic type. Such a difference in frequency of clinical manifestations are due to high sensitivity of nerves to the compression and irritation. So the nerves are very sensitive. So the clinical symptoms of neurogenic thoracic outlet syndrome are more. So what are the clinical features of neurogenic thoracic outlet syndrome? We will have tingling and numbness, paresthesias, and pain in the shoulder, arm, forearm, and fingers. Sometimes you may have a hospital headache and weakness of forearm and hand. If the motor system is involved, then you will have weakness in the forearm and the hand. So in neurogenic thoracic outlet syndrome, we have two types. Then upper thoracic outlet syndrome and lower thoracic outlet syndrome. So upper thoracic outlet syndrome is nothing but if the brachial plexus nerve roots are involved in the scalenus triangle. So usually you will have the symptoms related to the C5, C6, and C7 nerve roots. And then thoracic outlet syndrome. So it is the compression of brachial plexus in the costoclavicular space. So usually the lower roots C8 and T1 are involved in and are compressed. So we'll have symptoms related to C8 and T1 in a lower thoracic outlet syndrome. In upper thoracic syndrome, we'll have symptoms related to C5, C6, and C7. So arterial thoracic outlet syndrome. So if the artery get compressed, we will have a symptom related to artery, that is weakness, coldness, fatigue, upper limb claudication. Sometimes you may have thrombus in the arteries and paresthesias. Sometimes if it is uprooted completely, you may have gangrene or Raynaud's phenomenon and with a distal embolization. So if the venous system is involved, then we will have venous thoracic outlet syndrome. Then we have edema, venous distension, and collateral formation, and cyanosis. So coming to diagnosis, so diagnosis is usually clinical and we have investigations. So on a clinically on examination, we will have some procedures like Roos test or elevated arms test. So in this the patient is asked to abduct the shoulder at 90 degrees and flex at elbow and ask him to and external rotate with the heads in neutral position, and the patient is asked to open and close the hands in the fist while holding elevated position for 3 minutes. So positive pain and paresthesia and the distribution of dropping of arm is seen, and the sensitivity is 52% and specificity is 30 to 100%. So this is about a Roos test or elevator arm stress test. So false positive is seen in the case of carpal tunnel syndrome, ulnar neuropathy, and fibromyalgia. Something known as Adson's maneuver. So in this, the patient is asked to sit or stand in a comfortable position, and the patient is asked to flex the neck to the opposite side of the involved limb, and patient shoulder is abducted and the elbow is flexed at 90 degrees, and physician keeps a hand on the radial artery. So here so the affected side is abducted with elbow flex, and examiner finger should be placed on radial pulse. The test will reproduce symptoms or obliterate the radial pulse. So if the thoracic outlet syndrome is there and the arterial obstruction is there, then you will have a diminished pulse in the radial artery. So then if the diminished pulses are there in the radial artery, you can say it is thoracic outlet syndrome. Something known as Wright's hyperabduction test. Arm hyperabducted to 180 degrees, diminished in radial pulse. Neurovascular structures are compressions of corporate region by pectoralis minus tendon and head of humerus or corporate process. So this is how we will do the hyperabduction. We will do hyperabduction at the shoulder joint. So we can see the diminished radial pulse due to compression of arteries in the pectoralis minor area. So something known as Costoclavicular maneuver. So the patient sits straight with the arms at the side, radial pulse is assessed, and the patient retracts and depresses the shoulders while protruding the chest. We'll ask the patient to protrude the chest and depress the shoulders. So, and keep this position for 1 minute. There will be a change in a radial pulse or a pain and paresthesias, then the test is positive. This is known as Costoclavicular maneuver. Cervical rotation lateral flexion test. So a patient is seated and examiner passively rotate the head away from the epidemic side and gently flexes the neck forward to end range movement of the ventral chest. Posture forward flexion part of the movement is notably decreased with the hard and feel. So this if the left side is involved, we will ask the patient to flex and rotate the neck to the opposite side. Then you can see the reproduce the symptoms in the affected side. This is something about a cervical rotation lateral flexion test. So upper limb tension test. So we will ask the patient. We will ask the patient to stretch both the hands and abduct both hands, and we will see for and we'll ask the patient to flex the neck to the opposite side. So the symptoms to get reproduced, then we say that it is Thoracicoutletsyndrome is possible. The sensitivity is 90%, specificity is 38%. So whether to differentiate it is whether it is due to scaleness compression or scaleness triangle or other. We will do a lidocaine scalene block test. So under image guidance, either computed tomography, ultrasound, or fluoroscopy, anti-scalene muscles is injected with lidocaine. Patient with neurogenic thoracic outlet should have some decrease or complete relief of symptom for 4 hours. The initial lidocaine block is supposed to predict 90% success of subsequent treatment. So whether if the symptoms are very severe, and we have to differentiate whether it is due to scaleness anterior compression scaleness anterior, or the surgical intervention is any. If we are planning for surgical intervention, if it is the results are good or not, we can just assess by using this lidocaine scalene block test. So differential diagnosis would be the carpal tunnel syndrome, spinal canal tumors, sometimes angina pectoris, Raynaud's phenomenon, ulnar nerve compression. So coming to investigations. So in investigation, we will go with a chest X-ray or a cervical spine X-ray, and ultrasound and color Doppler, and MRI or a cervical myography to rule out the narrowing intervertebral foramina, disc compression, interspinal space occupying lesions, and a vascular angiogram, and nerve conduction and electromyography. So on X-ray cervical spine, we will see a cervical ring, elongated C7 transverse process, degenerative spine disease, bone destruction related to primary secondary neoplasm. So this is a chest and cervical X-ray showing the cervical rib and elongated transverse process. So this is X-ray showing the fractured clavicle with a callus formation and leading to neurogenic TOS. So ultrasound and color Doppler. This is a highly sensitive and specific test for venous stenosis and occlusion. I demonstrate increased flow velocity in subclavian artery at the site of stenosis in thoracic outlet syndrome. Arteriography and venography. Conventional arteriography venography may be demonstrated presence of extensive compression. It is replaced by less invasive procedures like CT, MRI, and ultrasonography. So CT angiography, MRI angiography, traditionally can be used to identify more clearly occlusion, aneurysm, thrombolysis, or distal embolization. They are also useful to plan surgical reconstruction. So this is the MRI angiogram showing occlusion at the subclavian arteries and bilaterally. So we can see in this case MRA magnetic angiogram, we can see the occlusion of subclavian arteries, stenosis of subclavian artery. So this three-dimensional CT image showing the arterial comparison relation of artery to surrounding anatomical structures. So coming to electrodiagnostic studies, nerve conduction studies are usually performed and usually normal in uncomplicated uh, neurogenic thoracic outlet syndrome. So we can see ulnar sensory potentials and ulnar motor potentials are reduced out of proportion to the median nerve in the case of the neurogenic thoracic outlet syndrome. So coming to treatment part. So non-operative treatment, posture improving exercise, breathing exercise, avoid aggravating activities, avoid repeated upper extremity mechanical work and muscular trauma, and you can use analgesics, muscle relaxant and antidepressants, and physiotherapy. So botulinum toxin A can be used for temporary symptomatic relief. Takes 2 weeks to work, but can last 3 months and can help patient progress with physical therapy. Botulinum toxin injection with ultrasound ultrasonographic guidance is safe and well tolerated in subjects with suspected neurogenic thoracic outlet syndrome. So coming to surgical treatment, indications of surgical treatment are symptom persist with the non-operative management, associated vascular compression, progression of neurological symptoms, nerve conduction velocity less than 60 minutes per second, millimeters per second. So surgical options are first rib resection and anti-scalenectomy. So first rib resection, complete resection of first rib results in superior outcomes. Anti-scalenectomy or anti-middle scalene resected. Anti-scalene middle scalene vessels are resected. And cervical rib resection if present. Transaxillary approach for or supraclavicular approach. If aneurysm is present, the patient may require arterial reconstruction in addition to first rib resection and first rib resection and anti-scalenectomy. So in the case of vascular thoracic outlet syndrome, surgical intervention specifically indicated for both venous and arterial thoracic outlet syndrome. Uniformly, all patients with arterial thoracic outlet syndrome will need full anticoagulation and varying degree of surgical intervention. So in milder cases, catheter-directed thrombolysis are usually done before repair. In severe ischemia, usually requires surgical embolectomy in conjugate thoracic outlet decompression. In venous thoracic outlet syndrome, anticoagulation is resumed after 3 days after first rib resection. And invasive venography performed 2 weeks post-operatively. Lesion-free patent subtract means the obstruction is not there, then you will stop anticoagulation. If there is a request endovascular treatment, then anticoagulation is continued for 1 to 2 months until follow-up. So in neurogenic thoracic outlet syndrome, approximately 60 to 70% of the patient can be successfully treated with evidence of activity that precedes symptoms. And selective use of pharmacological agents such as non-steroid anti-inflammatory drugs, antidepressant, and muscle relaxants. Physical therapy is also a very important component of these patients. Conservative management should be attempted for 8 to 12 weeks before considering surgery. So first we have to follow the conservative treatment. If it fails, then we have to follow it for 8 to 12 weeks. If it is not improving, then we have to consider surgery in this case. So if you are considering for surgery, then we have to do the lidocaine scalene muscle injection test. So it is positive, then you have to go for surgery. Response is low, then we will evaluate, and it is fit for surgery. So we will go with the first rib resection. As more and more patients are treated for thoracic outlet syndrome, the referral pattern has begun to change. Patients are being referred earlier with a shorter duration of symptoms, which improves their chance of successful surgical treatment. The ratio of presentation in adolescents has also been observed. Modern experience indicates that multidisciplinary comprehensive approach to thoracic outlet syndrome improves outcome. Although thoracic outlet syndrome has come a long way in the last half century, there are many avenues left to explore. The diagnosis still remains the most debated aspect of neurogenic thoracic outlet syndrome. Despite multiple menus and even the lidocaine scale block, the test results rely on the patient's pathology alone. Continued research would be beneficial to find a more objective analysis. Some have suggested using MRI or CTA preoperatively to compare thoracic outlet syndrome patients to control patients. Thank you.